Cool. Let's get started. First of all, thank you guys so much for joining us. We are so excited to have you, and we're even more excited to kick off our awesome Maimonides Zoom webinar series. Thank you for joining us. There's like 70 of us here on this call, which is amazingly awesome. Just wanted to remind you guys that there are going to be 6 parts to our webinar series, and this is the first one. It's going to be about how to be a rotation rock star. My name is Sabena. I am a PGY2 at Maimonides, and I'm originally from California. I went to Ohio State University for med school, and I found my way to Brooklyn for residency. We have such an amazing residency program here, and we are so excited to share more about it with you. Just some quick ground rules so you guys are aware. You can ask us any questions in the Q&A privately. You can share questions to the chat. You can even private message me on the chat. You can make new friends on the chat. There's many ways to reach out. We have this session set up as a webinar, so that automatically means that your videos are off and your microphones by default are off. So don't worry if you want to point and laugh and make fun at Duncan and just like have a bunch of Duncan jokes like I'll be doing. We won't know, we can't hear you, we can't see you, so don't worry about it. But please feel free to use the chat functions to reach out to us. Without further ado, I would like to introduce you to one of my awesome chief residents, Duncan Grossman. I want to give him a very flowery welcome. He told me, do not give me a flowery welcome, Sabena, so I'm giving him a very flowery welcome with a ton of bouquets, throwing you a bouquet, and a million roses. So we'll take it away. Thank you, Duncan, for your time. I'm sure all of the med students really appreciate your advice. I wish I had this 2 years ago, but I guess I did pretty well because I ended up with you. So take it away, Duncan.
Awesome. Thanks, Sabena. I'm going to do that awkward thing where someone tries to share their screen and then somehow messes it up. It's okay. I know it looks like it's messed up. Wait for it. Wait for it. Hamilton, wait for it. Oh my God, it fits. Okay. Hi, everyone. Greetings to, I believe the count is up to all 1.2 million of you streaming this live around the world. I'm Duncan. I'm very loud. You're going to be listening to me talk kind of a lot for the next 35-ish minutes. I don't know. We'll see how distracted I get. I'm really excited to be talking with all of you. Zoom has just been weird from the start. I have actually literally had to turn this light in my house off because the glare from my bald head will literally ruin your camera. So bear with me if we have some technical difficulties. First and foremost, congratulations to everyone on picking what is like clearly hands down the best specialty in medicine. I don't say that as hyperbole. Like, we have the coolest job. I'm just even going to tell you all the fun patients that we had in one shift today later in the presentation. Like Sabena said, I'm Duncan. This is a primer for all of you going into this field of medicine. And it's a bit of a weird time. No one's going to ignore that. I know some of you are in the middle of rotations now. Some of you may even be finishing rotations now, and some of you are going to start soon. I do hope you recognize that no matter where you are in this audition season, that you are actually, believe it or not, only a couple of months away from being able to give this advice to the next group of med students, which is crazy. So I think regardless of where you are in your training in this strange journey we're on, hopefully this will be beneficial information for you to take with you and to give to those who come after you. This is, I was trying to be poetic. This is a grain of salt that's like magnified like a bajillion times, directly stolen from Wikipedia. And basically the point of this slide is just to remind you that no matter where you are getting your information from, whether that is me, whether that is a mentor, whether that is a classmate, just take everyone's advice with a grain of salt. You know, I did not have the same board scores at you. I went to a DO school up in Maine. I was also an EMT for a while. Like, my background is very different than yours. I didn't audition during a global pandemic. So take everyone's advice, who's willing to give it to you, and really just sort of amalgamate all that and make up your own mind and sort of cater it to yourself. That's my disclaimer. I've divided this talk into 3 different sections, or chapters, if you will, because it's easier for me to truncate, hopefully easier for you to digest. The first chapter is just like what to expect, like what is your med student rotation in the emergency department going to be? Chapter 2 is, I'm going to spend a lot of time on. This is getting into the nitty gritty of like being on shift with your residents, with your attendings, with patients, and it's super fun. And then chapter 3, I'm just super unorganized, so it's just literally everything else I couldn't squeeze into there. Deep breaths, everyone. Just get into it. So I was really nervous to start rotations. I was nervous to start every rotation, actually. Third year of med school, fourth year of med school. There's always, it's a new place, there's new people, there's new rules. You know, what do I wear? Do I wear my scrubs? Do I always wear my white coat? Should I wear business casual? Is that weird? Should I wear a tie? It's a foam mic, blah, blah, blah. So hopefully this is gonna sort of dispel some fears and just give you a little heads up on what you're walking into. Day one of any rotation you walk into is so anxiety provoking, and yet it is like so painfully boring. It is just, it's paperwork. So just make sure you show up early. You're going to get lost. You maybe have been to this campus once, or maybe not at all. Just, 20, 30 minutes early to the site is not an unreasonable thing to do. 20, 30 minutes early to the room. I mean, people even do that too. Just make sure you're not the guy or girl walking in late. You're going to meet people on your first day. You're going to meet your clerkship director. This is probably one of the most important people. So your clerkship director manages your rotation. You're going to do painful amounts of paperwork. And then finally, someone at some point is going to bring up a slow. I know slows are crazy right now. I can only echo kind of what Cord and ASAP and all those people have said. One regular away audition slow. If you're auditioning this month and next month and maybe even the month after that, it's kind of implied you need a slow. I was told pretty early on, like, oh, make sure you ask for a slow on day one. Like, you don't need to do that. We know you want a slow. We know you're going into emergency medicine. Like, you don't need to do it on day one. You're with us for 4 weeks. Take a deep breath. It's okay. There's kind of 4 main areas of the med student rotation that I just want to draw your attention to and just talk about real quick. Shifts is probably the most obvious one. I just want to talk about all the learning sort of opportunities and duties and jobs that you have. Some places have a test, everyone wants to know about it. And then like the biggest one that everyone wants to know about is, am I going to get an interview at this place? Is that implied? What's that like? Is it guaranteed? So let's just start with shifts. This is kind of the most obvious one. So you're surprised you're going to be working shifts in the emergency department. These are going to vary wildly in terms of hours. So you may work 9s or 10s or 12s, or who knows, even a 6 here and there. Expect to work evenings, expect to work overnight, expect to work weekends, expect to work holidays. All of that is fair game in emergency medicine for the rest of your life, which is kind of fun. It's kind of fun to have a Tuesday off to go grocery shopping. Your shifts are going to be in different areas often. So some places have like pod systems. So you'll be in like pod A, B, C, blah, blah, blah. Ours is like a high acuity pod, a low acuity pod, lower acuity, although there's always someone hiding in there who's super sick. And then like the pediatric pod. And then, you can do optional shifts with the ultrasound team. You can do optional stuff with the EMS agency, ride the ambulance. This is, I think, what makes our rotations, our meaning emergency medicine, just harder than any other specialty. So like your buddies who are going into radiology or medicine or OB-GYN or whatever, usually paired up with like one person or like a small team of people, and everyone kind of gets to know each other. EM is bizarre because like day one you work with, Dr. Schiller, and you have to introduce yourself and sort of prove yourself from the get-go. And then day 30, you're working with like, Dr. Rashid, and like, you've never met this dude. He's never met you. And like, he's gonna be like, do you know about the perk rule? Like it all starts from scratch a little bit, and it makes our job hard. But it also makes it interesting because everyone has something new to offer. So take advantage if you can. You are there to learn, obviously, in addition to auditioning. But interestingly enough, I think this kind of escaped me when I was auditioning for emergency medicine, because it didn't really occur to me that the residents are learners too, actually. So the residents are going to have their own sort of like learning jobs and events that they have to do. So they have conference usually once a week. They may have a journal club. They may have something called morning report, where every morning at 7 or 8 or 9 a.m. everyone gets together and does a case. And they may have their own sim. And I will tell you, as a med student, I was involved in all of these in the resident domain. So I was accompanying residents to their sim. You're a med student, you totally outshine the interns. Not that that's ever happened to me on either side of that equation. So expect to be involved in a lot of outside shift activities, and you should get a schedule with that. You're also going to have dedicated med student learning time, which is awesome. So there are, hopefully going to be dedicated med student lectures. That's what your clerkship director's for. You may have your own med student sim, which is pretty sweet, actually. It's just a bunch of fourth year med students. I had a med student going into nephrology who was with me, who some guy who was getting intubated in our sim, and she wrote out a bicarb equation on our board. She's off somewhere making a lot of money, I guess. And then, they may ask you to do a presentation. And to do a couple presentations, I like presentations, so they were kind of fun for me. They're usually extremely low stress. No one's out to get you. It's usually not graded. They just want to see that you put in a little effort and learned a little something. And often if you do a good enough job and you show enough interest, they'll use that to sort of as a nidus for further discussion. Okay, that's enough about that. Is there a test? Maybe. Some rotations have a test, some rotations don't have a test. The ones that do have a test, often it's incorporated into your final grade, whatever that means. Sometimes that can portend your grade on the slow. I would not stress about this at all. Most of your studying for step 2 or level 2 is going to prepare you for a lot of this. And honestly, if you just Google, emergency medicine 4th year clerkship test, or SAEM has a test, I think, that a lot of clerkships buy and stuff. So if you Google SAEM emergency med student test, that should be helpful. Don't stress about this. This is not the thing you should stress about. Are you going to get an interview? I can't and won't speak for every program. I would say the overwhelming majority of programs interview the people that rotate at their programs, because you have to remember, it would be so silly for a place to have you audition at their shop and then be like, oh, we just sort of gave that spot to you, but we're not actually considering you for residency. That doesn't happen. We want to be able to work with you, see how you work. And then you get an interview at the end. The interviews, I will say the interviews I had at the ends of rotations really kind of ran the gamut a little bit. So some of them, the former program director at Maimonides, when I sat down with him, Dr. Saloom, dude's the man. And I'd spent a month with him. He knew me, we chatted and hung out, and he just sat at the desk and he goes, what do you want to talk about? And I was like, I don't know, should we talk about how much I like the program? I was sweating in my tie and stuff. So by that time, we know you. It's a little bit of a formality, but maybe it'll open up the doors for some other conversation. Okay, wait, sweet background color change. Check this out. Oh, chapter 2! Chapter 2 on shift, nitty gritty. This is the fun part. So I just wrote down some of the patients that my team had today on the high acuity side. So this is why our specialty is cool. So we had a dude with a MI. So our normal trope is up to 0.02. His was 45 when he came in. We had a GI bleeder. Oh wait, I had 2 GI bleeders, both who had cardiac stents, both who stopped taking their Plavix. Very, very weird. I had a pediatric trauma with a subdural. What else I have? We had a cardiac arrest. The intern got to intubate his first, oh my God, he's a recess resident. Danny got to intubate his first patient of 2nd year. Maybe this weird COVID case versus endocarditis, and then a patient on a ventilator with absolutely nothing. She came in with absolutely nothing. She got a crazy workup. She had nothing. And that's why our specialty is so cool. This was let's see, cardiologist, gastroenterologist, trauma surgeon, pulmonologist, COVID, infectious disease. Oh, it's just crazy. Our job is so cool. All right, let's talk about what being on shift is actually going to look like, and some suggestions for kind of how to get through the day. Whatever time your shift is, for the love of all that is pasta, please just, sorry, pasta in the back. Wake up early, do everything you need early. Don't be the late person. Goes without saying, everyone's going to tell you to do it. Just shower, just put on something that smells nice. If you're carrying a backpack with you, or if you eat in the morning, just like stuff snacks everywhere, ready to go. Get your white coat on, get your gear. I carry calipers with me because I'm a dork. Give yourself a little wink in the mirror. Positive affirmation, always good to start the day. I like to listen to SpongeBob the Musical when I'm going into work. It makes me feel good. Don't judge me. Whatever your mode of transportation is, early. And also just on your way in, consider listening to like a podcast on the way in, just to sort of like get your head in the game for emergency medicine. It's also sort of like a subliminal way to study almost. If you just listen to something every day while you're going in, you're studying without even knowing you're doing it, which is pretty cool. Okay, you're gonna get to the emergency room. You've had a tour by now. It's gonna feel chaotic. There are patients literally everywhere. This is our emergency room. They just redid it. Fun fact, it looks the same. All these people have like a purpose of being here, right? The patients are like, I want to get tested, or like, I want to leave even though I came to get tested. And the nursing staff is like, I have to draw blood. Like, everyone has a duty there, and you're going to show up and be like, I don't know what to do. And you're going to turn the corner and there's just going to be more patients. They're going to line the hallways and it's going to be frustrating. I don't know why this guy is jaundiced. It seems like a bad thing. This is the other side of our emergency room, which is the same. Rectal exams, sometimes a problem. It's okay, relax. Just find someone, walk up to them with your big smiling face and your white coat and say like, hey, I'm so-and-so. I'm one of the med students. Make sure that they know that you're not bald, that you're not going bald, that you will never be bald, and life is okay. And then if you know who your attending is, just ask for that attending, or if there's like a doc box where they all meet, or just ask like, where does the 7 to 4 shift usually meet? Someone will direct you over there. And then you'll get to introduce yourself to your attending. And maybe your attending will be world famous emergency physician and pickle connoisseur Ruben Strayer, wearing a strange hat that says make droperidol great again. When you get on shift, introduce yourself. Hi, I'm so-and-so. I always like to say the hours of my shift early on. So you're attending, maybe working 7 to 7. If you show up and say, hey, I'm Duncan, I'm your med student from 7 to 4, it avoids that really awkward time at like 3:59 when Dr. Strayer is like, I'm gonna go pick up this really interesting patient. I think it'll be good for you. And you're like, my plans tonight. Say your hours at the beginning. Be prepared for the question of what are your goals for today, right at the beginning of the shift. It'll be really nice if an attending asks you that, and sometimes they do. But even if they don't, it really sort of sets your mindset in terms of like what you're trying to work on and what you're trying to gain out of a shift that day. And it's going to help you with feedback, which we'll talk about a little bit later. So introduce yourself, say your hours, be ready for the question of like, what are you working on today? Or, what do you want to learn about today? Probably the last most important thing is to ask your preceptor, whether that's a resident or an attending, is like, what do you expect of me on shift? Pretty simple question, but does 3 super, super important things. First of all, it shows that you actually care, that you're enthusiastic, you want to do well. It also just tells you what to do, which sounds obvious, but sometimes in the emergency room, like you pick up patients, or the resident assigns you patients, or the attending picks patients for you. There's kind of like all these like unspoken rules. So ask them what they expect you to do on the shift. And this also really helps your preceptor kind of figure out what they are expecting out of you. So if suddenly you came up to me and you're like, Duncan, what do you expect me to do this shift in terms of like picking up patients and working them up and presenting? Suddenly I'm like, oh, we should like have an algorithm for this, or like we should have like a set of like guidelines for you, so you're not just like in the parking lot talking to one of the locals about the patient. Okay, this is the cool part. This is what you trained for. This is why you did all those like, what are they called? Like OSCEs, or like, I don't know, all the standardized patients that were like super awkward and stuff. This is your time to shine. So all of your patient encounters will probably start at the computer, which is a really good place to start, because there's a couple really key pieces of information there. And just for this slide in particular, I want you to just think about like, this is how I should think about approaching a patient encounter from beginning to end. Start at the computer and look at three very, very important things. The first thing to look at is their vital signs when they get triaged. Do they have a fever? Are they tachycardic? Are they hypotensive? Do you need to tell the attending right away? They're going to have medical history in there that often the patients just don't remember or don't know about or can't communicate with you because of like language barriers or developmental delays or whatever. And the most important thing is a triage note. So someone, to be in the computer, usually someone has seen this patient and the patient has said to them, I have chest pain, let's say. Before you go see this patient, you've written down their history, you've written down their vital signs, you took a look at the triage note and it said, I have chest pain. Before you get there, you're gonna have to do a very targeted, focused HPI review systems and physical exam, right? So if someone's coming in for chest pain, just write down on a sheet of paper, like all of the scary things that come with chest pain that have to be considered on every patient, even if you're not working each of them up, and just have them on a sheet of paper to reference. So this way, if you get there and you start asking all your crazy ROS questions like fever, chills, cough, nausea, fatigue, vomiting, oh God, I'm lost. Okay, I need to rule out pulmonary embolism. Oh, okay, that's easy. Are you on OCPs? Do you have any unilateral leg swelling, any hemoptysis? Do you have, is your chest pain pleuritic? Don't ask me like that, but you know what I mean. Or are you thinking MI? Does the person have a history of MI? Do they have a family history? Are they a smoker? Blah, blah, blah. So use this list to sort of like help you go through review systems and an exam also. If someone's coming in with abdominal pain, like don't get caught with your pants around your ankles because you're working up cholecystitis when you go back to the computer and you never ask the patient like, oh, do you still have your gallbladder? Okay, I need to do that. All right, oh, mesenteric ischemia is on my list. Okay, do you have a history of atrial fibrillation? Have you been taking your Eliquis? Blah, blah, blah. So write down chief complaint and then like scary things that may happen. And then you have to do the fun part, which is you get to go see the patient. I am so proud of this slide. I'm just gonna play that animation again because this took me like an embarrassing long time. Look at that. Look at you going to see patients, you Rockstar med student, you. Hopefully, like in the slide, your patient will just like sort of apparate out of the blue. Do the thing you're trained to do. Get a history, get a focused review of systems, and do an exam. Your exam should also be appropriate for the patient. So if they're coming in with headache, if they're coming in with, like, oh, my left arm is numb, full neuro exam, cranial nerves, motor, sensory, finger to nose, walk them, the whole thing. If they're coming in with chest pain, check their legs for edema, for PE. Be very targeted in all the things you need to do. Okay, so you spend enough time with the patient, you're gonna go back and your attending is gonna come up to you and your attending, my dog is about to bark, apologies everyone. And your attending is basically gonna ask you like, are you ready to present? Thank you, Gordon. This is an okay time to say, you know what, I actually need 30 seconds just to gather my thoughts. And for good reason, because your patient presentations are going to be a work in progress throughout all of residency, probably throughout the beginning of your attending career too, as you're like thinking through patients, the way to think through patients. So here are a couple ways to think about presenting patients. Here's some resources. Don't worry about writing them down. I have them all listed in a document at the end of the PowerPoint. So there is this like very famous 3-minute emergency medicine medical student presentation published by SAEM. It's good. I think most people that I've talked to agree that 3 minutes is actually like a little bit long, but ultimately not the point. This has a lot of really good things in the last couple of pages of this document that can sort of help guide you to have a catered presentation. I am not a reader. I cannot do that. I'm gonna tell you what my favorite source is, and that is Anna Pickens' EM in 5. Her whole website is just gold, and her patient presentation for med student video in particular is quite good. It's 6.5 minutes long. You can watch it like 30 times. You can watch it every day before shift. You can watch it on shift if you're getting lost. It's great. Also, a committee I'm part of called the EMRA Education Committee made this pocket card called the Patient Presentation Guide. And so if you really need a quick reference and you're like, oh crap, what am I supposed to have in my plan again? Just take out this card, take a look at it and be like, oh, okay, I need labs and I need imaging. Oh, what's my treatment? And then, like, oh, that's right, I need to have a dispo for this patient at the end. I'll link you to a PDF of this at the end. Really, really good stuff. That team worked really hard on it. Regardless of which method you use to sort of learn how to present patients, I think most people agree on kind of like 3 core things with patient presentations in the emergency room. First of all, it just needs to be short, like 60 to 90 seconds, probably. Take it with a grain of salt. I think that's probably an appropriate amount of time for someone to be talking. A lot of times people will tune out whoever is presenting, even if that's the resident, after the first like 20, 30 seconds. So if you have like a great killer first line, not to harp on PE, but like, oh, I'm here to present with you a 24-year-old female on OCPs with unilateral leg swelling who's coming in with hemoptysis and shortness of breath. Like, I don't need to hear any more of the presentation. Like, we know the workup. Keep it short. Always include first worst diagnoses. It is so interesting, like when med students present to you, because they're coming to you with someone who is like so clearly musculoskeletal pain, who like lifted a box weird yesterday and is like point tender on like this part of their clavicle. It's like not even chest pain. But you as the med student, your first words should not be, I think this is musculoskeletal chest pain. No, your first words should be, I don't think this is a myocardial infarction because blah, 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 blah. And either I want to rule it out with this or I don't care about ruling it out. You don't have to work up every first worst complaint, but you have to address each of them. So just bring them up in the beginning. And finally, if you really want to stand out from your peers, this is sort of a common theme from when I rotated, and that is true now. Have a plan. Have a plan without being prompted to have a plan. There's always kind of this awkward silence, and I'm sure you guys have felt it because I have certainly done it and felt it too, where you go to present a patient and you say, this is a however-year-old person, their vitals are this, I do their exam, and then there's like silence between you and the resident or the attending, and someone like says, okay, so what's your plan? If you can give that without being prompted, you are ahead of the game. So if you finish your exam and say, I don't think this is a myocardial infarction because the pain's been going on for 6 months and he has known GERD and he has no family history and he's 19 years old and he lifted weights yesterday. I don't think we need a troponin. Like, awesome. Keep that up. Try and say your plan without being prompted. You're going to have downtime on shift. Kind of a surprising amount, because remember that residents are learners, and remember that residents and attendings all have like clerical work to do, basically. You can be really kind of helpful during this time, believe it or not. I always thought I was just sort of like a bump on a log when I was a med student. Not true. Like, effective med students are extremely, extremely helpful in the emergency department, and it makes you look good. First thing you can and should do for you and for the patient and for your preceptor is to go reassess the patient. So if you gave someone nebs, go listen to their lungs again. If you gave someone pain medicine, go ask if they need more. That'll really help everyone from like having to go reassess like 5 times, and it shows that you care. I kept a journal or like a little spiral notebook of all the interesting cases I saw and all the interesting patients that I carried. Highly, highly recommend that you stuff that in your white coat or wherever. Take a look at some online stuff or at some apps to like read up on your patient's diagnosis, ask like informed questions, query about other diagnoses and workups and stuff. It just shows you care, and it actually just helps you like cement the information of the patient you saw. If you're really bored and you already checked up on your patient, or you have no patient, and you don't feel like reading up to date awkwardly on a computer in the corner, like go be helpful out in the emergency room. Like, go hang fluids, go start IVs, go wheel someone to CAT scan, go walk someone to x-ray, like all that stuff, immensely, immensely helpful. And keeps you busy, and you'd be surprised how much you learn from everyone else. And that brings me to the last thing to do on shift also is like introduce yourself to everyone. Your nurses, my nurses, I will say, teach me stuff all the time, especially my like high acuity nurses. Like, oh man, they catch my mistakes every day. They're really incredible. So get to know them, respect that you can't, I'll speak for myself, I cannot do their job. I just can't do their job. I think a lot of them could do my job because they rock. So be nice to everyone. I can't tell you how many like anecdotal stories I've heard of like, oh, I was really nice to a nurse and she wrote a letter to the program director for me and then I matched there. It's kind of that old adage, like you're always auditioning. This is a tough one. This is asking for feedback. This is hard for a lot of reasons. So first of all, not everyone is trained to give feedback. So sort of grains of salt with this also, but also just appreciate if someone is going to actually give you legitimate feedback instead of like, you saw a lot of patients or like, good work today, read more. Like, it's embarrassing if I give that feedback to a med student working with me because it kind of means I didn't like put in any effort to like really pay attention. At the same time, if you're asking for feedback, the worst question you can ask is, so do you have any feedback for me? It's extremely vague. It puts everyone in a weird spot. If you did what we talked about earlier and sort of set some goals for yourself and sort of like things you were trying to learn or work on, you can actually be really pointed about your feedback, and you can say, what did you think of my presentations? Were they too long? Do you feel like I put enough first worst diagnoses in? Did you take a look at my note? Was it too lengthy or wordy? What do you think of like the narrative structure? If you want to get like literary about it, do you think I should carry more patients? I felt like I had one. I feel like I can carry more. So if you're pointed with it, someone should give you feedback, ideally, and just take it, especially if it's like, quote unquote, critical feedback and constructive feedback. That's a really good thing. Sometimes it like stings a little bit to be like, oh, I really thought I had a handle on my physical exam and someone told me to get better at it. Always question where it's coming from, but like really take it to heart and be like, you know what, I am still a med student, or like for me, I am still a resident. I am still learning, and I should work on stuff. I should continue to work on stuff until I retire, probably. That was chapter 2. Sabena's taking a swig of water. I'm taking a swig of water. This is that like potpourri chapter that just has like a bunch of nonsense in it that I couldn't fit anywhere else. I think it's actually going to be pretty high yield though. One thing is like a random rotation thing to ask for, and then I'm just going to go over like a ton of resources for you, and you can sort of like pick and choose. A lot of places have like a mid-rotation eval, and so they'll offer you a chance to like sit down with your clerkship director who's running this thing and say, hey, if you want to like come in and hear about your reviews so far, your feedback so far, now might be a good time in the middle so you can improve in the future. And if they don't offer that, that's okay. It is totally not out of the norm to be like, hey, would you mind if we sat down for like 15 minutes this Wednesday, just so we can go over my my feedback, my evals, and I can improve for the second half of the shift. Maybe you're doing something weird like chewing gum extremely loudly in everyone's ear all the time, and everyone's eval says like, I really wish Duncan would stop chewing gum in my ear. That would be good for you to know. I was gonna have a slide in here about like how to know if you're being annoying. Not because any of you are annoying, you're all wonderful, but I was always afraid I was annoying. And I was like, how do I know I'm not being annoying? Because annoying people don't know they're annoying, right? If the advice I wish I had gotten was basically like, just to put my own mind at ease, to be like, am I being annoying? If your preceptor says like, I'm good for a minute, or like if you're like, oh, can I see a patient? They're like, no, it's okay right now. Like, I'll let you know. Like, it's not a hint that you're being annoying, but like they probably have charts and paperwork to do. So go do any of those things we talked about earlier. Go like reassess patients, go do some reading, go walk people to x-ray. And you don't have to be like seeing a patient constantly. That's kind of what I would say for that. That was like a side tangent, but we're in the purple section, so it's okay. So many resources we're going to go over. I'm going to give you my favorite resources and little snippets about them, and you can sort of just choose if you want to look into them or not. That's fine too. These also will all be in the PDF at the end of this talk. I love podcasts. I don't have the attention for reading. There won't be a lot of books in this section, unfortunately. I think they're great to listen to on the way in, and I think they're great to facilitate studying. So things to listen to on the way in. This EM Clerkship podcast by Zach Olson is awesome. They're very short. They're aimed toward med students. This one right here is called the Emergency Medical Minute. This is basically the morning report sections out of Denver. These are not good for studying because they're very like all over the place. They kind of pick whatever topics they want, but they're really fun to like hear little nuggets of trivia and stuff. So these are really good to sort of listen if you've got like 4 minutes until you walk from the train to your thing. If you're looking for some like longer form stuff, EM Basic is kind of, it's an older podcast now, but it's still extremely relevant. They're much longer. They're like 30-ish minute podcasts that go over like very core emergency medicine content, like from intern level. And you should be striving to work at the intern level. It's really, really good. Core EM, very similar. Their later episodes are a little more niche, but their very early episodes really tackle like very core basic emergency medicine. So they're excellent. MRAP, if you don't have a subscription, oh my goodness, get a subscription. Their production quality is just through the roof. And they have everything from like short little like 60-second snippets on like flexor tendinosynovitis to like, I mean, chapters and chapters of how to treat pulmonary embolism. You can get lost in here, but if you have a topic you want to learn more about from either EM clerkship or EM basic or core EM, is a great place to go. If you're looking for something a little more advanced or really want to kind of get into the critical care resuscitation stuff, MCRIT by Weingart. If you haven't listened to this, it's awesome, especially the earlier stuff. I feel like an old dad talking about music albums. It's weird. Really, really good. And I would say it's definitely like sort of a step above, but if you have questions, if you're like, I don't care about otitis media, I don't care about strep throat, I don't care about gout, like what do I do in the septic hypotensive patient? Like this is your podcast you should listen to. If you're doing any pediatric shifts, this guy, Tim Horshenko, is awesome. His podcast is excellent. So those are the podcasts. Like I told you, I'm not a big reader. These are kind of the books that I've like seen and dabbled with that have been helpful to me. So I have my wife told me I needed a prop. Hold on, let me get my prop. Oh gosh. I don't, okay. Pretend this is the book, because this is about the size of the book. This is the Tintinelli's like manual, which is not the full textbook. The full textbook is like a gazillion pages. Please don't carry that to the shift. But the manual is kind of nice because you can bring it in your backpack to the shift and just look up stuff if you want. And it's also nice to study from at home if you're interested. Just buy it used, it's fine. Or don't buy it if you don't want to read. That's cool too. They have this like just the facts book, which I've thumbed through a little bit. It physically is bigger. It's like, meh. Very abbreviated. It's like a good reference. If you don't know where to start on EKGs, this is like really the, no pun intended, gold standard. Get it? It's gold. Just read it. You should know how to read an EKG at least a little bit. And then if you feel like you've got this, you're like, I know rate rhythm access, I know the QRS. If you really want to start thinking like an ER doc, this Amalma 2 book is awesome. It tricks me like every other or more often EKG. They're really good. There's some apps. There's some apps you definitely should have, and there are some apps that you can have if you want. This one, up to date. You should have a subscription through your school. Just download it. Just have it on your phone, ready to go. There's no reason anyone should ever not have MD Calc on their phone, especially in the emergency room. We have like Nexus criteria, PERC rule, heart score, Canadian syncope, like all of the stuff that we always constantly use. Download MD Calc, use it. There are these two. This one's Palm EM. It's $20. I did not buy it because I am cheap. The screenshot look really good. So if you are like independently wealthy and want to show off to everyone that you have a cool app, you should buy it, I guess. It looks cool. Do you need it? No, you don't need to spend money. This one I actually did buy. This one is $5 on the App Store. This is PediStat, PEDI space stat. And this is basically like all your pediatric emergency medicine stuff. This has like a Broslo tape built into it, which is pretty cool. My favorite resource is videos. So again, MRAP has their own video series. So again, if you don't have a subscription, I highly recommend it. I guess I should have said, I have no financial interests, obviously. These guys are awesome. EMN5, Anna Pickens, she has her own website, and these are also all on YouTube too. This is Emergency Medicine Updates by one of our attendings, Ruben Strayer, the world famous emergency medicine physician and pickle connoisseur. His lectures are so good, and he focuses on very specific topics, and they're like core topics. So his lecture on like when to take an airway of someone is fantastic. So I will link you to that at the end. And then this is a group out of Canada, emergency medicine cases. I just started looking at their videos. Really good core stuff. Encourage you to check it out. Okay, the last and most important thing is to just like have fun at your rotation. Like, this is potentially where you're going to be spending the next 3 to 4 years of your life. Like, I don't know if you have family, but like you're going to be bringing your family with you. You're going to be like just living day. Like, one of the best pieces of advice I got when trying to rank places was like, can you see yourself waking up at this location every day? And that really had an impact on my rank list. Why I chose Brooklyn, because it's awesome. Just explore everything. This is like my wife and I walking across the Brooklyn Bridge. We eat a lot. We visited Nathan's Hot Dogs in Coney Island. Smorgasburg in Brooklyn was delicious. This is me and, these are a couple residents. This is my wife, who's currently in the background eating pasta, riding the Cyclone, mini golf. I mean, just like, you could do what we did, like idiots, and just adopt a dog and be like, we live in a new place, let's get a dog. Us eating. Oh my God, wait, I just have to tell you about this place. So this place is in Queens. Victoria, what's the name of the Momo place? Can't remember. Anyway, this is like salted butter tea in here, which is very specific in flavor. Their momos, their dumplings are awesome. This is us pretending to be birds at the Botanical Garden, which is opening now in phase 4, which is exciting. Greenwood Cemetery, which is like this big famous thing. So wherever you go, like, you know, if you're near a city, like most of these big academic institutions are near something rather historic or just like approachable. Like, just go explore. I know COVID's weird and I know stuff is closed, but like, do what you can and really get out there. Okay. Please reach out to me at any time. I'm happy to mentor, answer questions, be mocked openly. It's all good. Just email me. It's my personal email. Thank you to Sabena and her crew for letting me present this to you guys. Also, a big shout out to this guy, Adam Kellogg, out of Bay State in Western Mass. If you don't know him, he runs the EM Advisor blog on the internet, which is, it's like so good. It is just gold. He actually, his education fellow just 2 or 3 weeks ago just posted how to be a Rockstar rotation, how to be a Rockstar med student on rotation. And it's awesome. She goes very in depth. Really highly encourage you to check that out. And actually all of this information that I gave you was also posted on that blog. If you search how to be a Rockstar med student, should link with the QR code. Please stick around for awkward silences and questions. Sabena, do you have any questions that are ready to go that you want to ask or talk about?
Duncan, that was awesome. I could apply all over again. Or maybe you should just audition me on shift tomorrow. Please don't do that. Yes, we got a question from an anonymous attendee. The question was great, and thank you for that question. The question was, how do you pick people to interview this year since there are less away rotations and away auditions?
I don't know.
I have a quick answer since cool. You texted that to us about 30 minutes ago. So I texted our clerkship director, and I'll just read off exactly what she said. She said, we still view applicants the exact same way. STEP, med school grades, letters of recs, extracurriculars, SLOs, research, and fit. Like, it has to be a good fit for you. It has to be a good fit for us. We want you to be happy. We want to be happy. It's not to be underplayed. But we're just looking for people who are kind, hardworking, and who want to be a part of that specific community. So try not to stress. I can't even imagine how stressful the situation that you guys are in is. But it really comes down to like the same bread and butter algorithm, and then just wanting to be somewhere and making that, not even just wanting to be somewhere, but making that known that you want to be somewhere. So that is what Jeanette or Dr. Corbettin says, and my little elaboration on that too. We have a couple more questions coming in. Duncan, I'll throw this one to you. Any tips purely for EM ultrasound rotation?
I actually did a purely EMS ultrasound rotation, ironically enough, at Adam Kellogg's institution at Bay State. One of the most like educational and rewarding rotations of my med school career. I like came into residency ready to go with ultrasound, which was awesome. tips. Ultrasound, everyone and everything, always try and get your hand on the probe, even if you are like scanning as a group and you finish scanning, just like ask to hold the probe for a second. The more you hold the probe, the more you're gonna learn from it. There's also something you can do called, depending on like, how do I say this? So like, I don't know, some people need like very specific ultrasounds, but some people are like kind of vague complaints. So you can do what's called fraggling them, which is doing a fast, doing a renal, doing an aorta, doing a gallbladder, doing a lung, and doing an echo. You can just do everything on them. So if you're required to get numbers, that's how we got numbers a lot of times. But just hold the probe as much as possible. Ultrasound IVs, super, super hard when you're first learning to do them. Do them as a med student, mess them up as a med student.
Do them in residency, mess them up in residency.
For sure, for sure, for sure.
Yeah. Next question. Do you still consider US IMG students for residency?
We had a bunch of IMGs rotate with us last year, actually, from George. And then my chiefs, when I was an intern, 2 out of 3 of them, I think, were from SGU. So yes, still considered. I don't think we've matched them in a couple of years, but yes, still considered.
Absolutely. What's it like to have a family during residency in general and specifically at Maimonides? Duncan is a somewhat parent to a dog, and we're both happily married people as well. We don't have kids, so we can't necessarily speak to that, but we do have co-residents who do have partners and children, and I can't speak to their experiences exactly, but I would like to think that it's a pretty supportive, at least Maimonides is a pretty supportive program for having kids, whether or not you're like planning on having a family and you're pregnant and you're going through that experience and kind of finagling your rotation schedule and your work schedule to what would fit your lifestyle. I think that Maimo for sure is accommodating to that, but EM in general as a just like an industry is very, very family friendly. I think that we are the coolest people in the hospital, in and out of the hospital. So I think that most places should be pretty accommodating to that. I will say one quick thing is when you're going through this, I mean, somewhat clunky online dating interview trail, just look at like what the residents' lives are like and see, does that kind of mirror your lifestyle or a lifestyle that you're excited to live as well? I mean, you don't need to have the exact same version of yourself across, every single resident, but maybe just a couple people who are like you and you can resonate with. And if that's like a good fit, then I think that should be okay. Duncan, do you have anything else to add about that?
Yeah, my wife is laughing in the background because literally like all of our PDs and APDs, I think, just gave birth within the last like 3 days or something.
They did.
Yeah, like everyone is a baby. A lot of attendings have just had babies. A lot of residents, when I was an intern, took time off to have kids, and they like adjusted their training schedule accordingly, and it was not an issue.
Couple other questions that are coming into the chat. Thank you for putting this together, says Loria. So helpful. Is using your phone on shift while to look at apps like WikiEM and EMRA Antibiotics Guide frowned upon?
That is such a good question. I feel like Sabina's shaking her head no. I'm going to disagree. I'm going to say be on your phone as little as possible, even if it is looking up important medical information. There are caveats to all of this. So if it is like obvious that you're like, oh, let me look up that score and like pull up your phone, that's cool. If you're like sitting in the corner studying on your phone, it's going to look like you're on Instagram. So if you're doing like a very obvious data collection moment, fine. I will say, I just talked about this with one of my buddies, Sam Broder, who I graduated with, and his take, he's a little bit older than me, and he's like, don't be on your phone. Even looking stuff up, like, don't be on your phone. If you can avoid it, great. If you can't avoid it, then that's okay, as long as you're making it apparent that that's what you're using it for. That's like a weird answer, but just don't like bury yourself in your phone, because people are going to think you're just tweeting or something.
That's true. Duncan's right, but that doesn't mean still use those resources. Just use it, I guess, wisely. Okay, Victor asks, what would be your tips for showing interest / our personalities and making that connection over Zoom during interviews?
We're officially reaching like uncharted territory. Okay, so first of all, okay, this is we have jumped off the ledge into Duncan opinion land, and Duncan has no data or information land. So anything I'm about to say, just like asterisks all over. First of all, don't show your opinion by wearing like funny hats and funny weird office Zoom backgrounds. I wouldn't start there. I think unfortunately interviews, even in real life, are often like kind of sterile and a little scripted in a way and a little formulaic. I don't think that that is necessarily like the place where you are going to get your personality out and about. I think like the way you carry a conversation and the way you speak, like hopefully just from the short time we've spent together, you kind of get an idea of how I am, and that stuff just automatically comes across like pretty naturally. I'm not sure that I would necessarily like go out of my way to show a personality that's different than what would just be in a room with, you know, a suit that's too tight at the end of interview season or whatever.
I would plus one that. I would agree. I mean, you know, those moments that you sometimes have where, well, I could say this or maybe I shouldn't. And then you're like, well, this is who I am. I'm just going to say it anyways. Maybe in that moment, just share that joke with Gordon or Duncan and me. Like, that's totally fine. But I have been that person who's like unapologetically myself. And we want you to be that. But, you know, it's just such a small snapshot of time that you get with someone, and it's so unfair that you guys have to do this on interviews, but it is how this season is going. So yeah, I would just say, just, you know, be yourself, but just be smart about it. Well, other question, will our personal statements / other activities matter more since everything is sort of in flux, aka step 2 CK being rescheduled to random times and no aways?
Personal statements so I'll speak to like pre-COVID times. Personal statements, the general rule of thumb that I had heard, that I had followed, and the advice I gave was it is better to have a generic, unremarkable, kind of vanilla personal statement than to like make a statement. Again, sort of like coinciding with this like weird culture we have in medicine of like being proper, being official, being what's the word I'm looking for? I don't know. It's like a little more formal, basically, I guess. So I don't know that I would necessarily say your personal statement like counts more, but that's always the advice I give to everyone. In terms of the other stuff, I just don't know. I don't know. It'll be up to like each individual recruitment committee.
I got one piece of advice with respect to personal statements when I was applying to residency, and I think it's great advice. So what she said was all personal statements exist on a bell curve, and you want to make sure you are not in the little part of the curve that sucks. And as long as you're not in that little sliver, which I'm sure you guys will not be, you are fine. Like, you are probably not going to change the world with your personal statement. No matter what you say, unfortunately, it's probably been said once before. So just make sure it doesn't suck was the advice that I got. And I loved that because it took a little bit of the pressure off of trying to be this unique butterfly. And it just made it be like, okay, this is why I like the field. And this is what I hope to learn. And this is what I hope to contribute. And this is what I want to do. And it was fine. So don't stress about it too much. Just make sure you're not in that little sliver on the left side. Cool. Marcus says, great presentation. Thank you to Duncan. Nabila asks if we can say Maimonides 3 times fast. Go, Duncan.
Maimonides, Maimonides, Maimonides. What's really funny is people that have worked here for decades still pronounce it wrong. They say Maimonides. They like, you're like, John, you've worked here forever. Why are you saying it wrong? We always call it Maimo. Some people call it Maimo. And I'm like, you're saying it wrong. But like the people, they're usually people from Brooklyn. And you're like, oh no, am I saying it wrong? Maimonides, Maimonides, Maimonides.
Maimo is super safe to go with. Just say Maimo. I want to make sure we hit this question. Guys, we're going to stay on to make sure we answer all your questions. So don't freak out if we haven't answered your question your question yet, and it is 8:58. Don't worry, we're here. We're here to help you. One thing, Duncan, I want to make sure that you can answer to is any concerns with DO versus MD while rotating, pearls for DO students specifically?
Thank you for asking that question. My wife's just staring at me, so I'm just stumbling over my words. I think there are a lot of DOs on here, actually, when I saw the email list go out. Being a DO going into emergency medicine is tough. It just is. I don't think it's going to necessarily be tougher this year. It's really interesting. So on Adam Kellogg's website, he talks about EM becoming more of a competitive specialty. There's a really great graph on there that basically shows the number of applicants like shooting up, but actually the number of spots also shooting up, which is kind of nice because it means that we are increasing the number of spots at the same time we are increasing the number of applicants, which is good. DOs in particular, here's what I would say. Yes, take step 2. It's not a question. It's a statement. Grains of salt, but take step 2. Oh my gosh, take step 2. Take level 2, take it seriously. Very few people commented on my level 1 and level 1 and level 2 during interviews. In the past, I would say, because most DO institutions or schools don't have a home institution, it was more important to get more rotations. So I actually did 3 formal aways and then an ultrasound rotation and a pediatric EM rotation. Obviously not the case now. With that said, if you can get some of those ultrasound or EMS or pediatric emergency medicine rotations, I think that would probably be beneficial to you as well. I would not try and cheat the system by getting multiple formal slows, doing multiple aways if you can avoid it, unless your circumstances are extenuating. It's tough. It's going to be okay. You're going to get through it. I did it. All my friends did it. It just is. It's just harder. And I think a lot of people who aren't in osteopathic programs appreciate that as much. So know that it's tough. No, I get that you have to like travel from, I mean, I lived in 5 states, I think, during my 4th year of med school. Like, you know, take advantage of whatever adventure you can, but I understand it's tough, and email me if you have questions.
Someone was asking about having an audition rotation schedule for the first week of October, or would that be too late, or would residencies be looking at applications at the end of October or even the first week of November? This year is different. I mean, everything this year is pushed back a little bit, so I think that like ERAS in general is open a little bit later. Duncan, do you happen to know the answer to this?
I don't know the dates. I will say that if you're interested in a place and you can get a rotation there, and it happens to be later in the season, even if that's in like November, you should do it. That's the best way to show interest, is by actually rotating at the place. So whether or not it will, I apologize, I don't remember the timeline of when letters and applications are doing ERAS. I know that after applications open, you send them in, you can later upload letters and slows. So just because like ERAS opens or whatever, doesn't mean that like you can't add to your collection. And I definitely did that when I applied. I added slows late, which was intentional, which I knew was going to happen. So that's what I would say for that. If it's a place you want to go, then go for it.
Absolutely. I completely echo that. Especially like, you know, that one extra slow may not change the entire trajectory of like all the interviews that you may get, but all you need is one place that you really love and that loves you back. So I would say if you are really jazzed about a program, again, make it known. This is not like a silent like game of dating. This is a like open communication where you tell a program that you love them and then they you know, file that in their information bank. So yeah, even if it's November and you're really jazzed about a program, make it known and see how you can get your face seen there. Someone's asking about how is Maimo's COVID response? Do folks think that there were things that could be done better? I will just do a quick pitch that we are doing a full session about Maimo's COVID response. It will be actually resident only panel in a couple of weeks where we just kind of reflect on our experiences there. But I don't want to dismiss your question. Duncan, I'll pitch it over to you.
Could we have done better? I think every hospital in the world could have done better, probably. This is still a disease that we don't know enough about and that we are still learning how to treat. even months and months and months after it has been discovered and already dealt with in multiple hospitals and countries. Maimo in particular never ran out of ventilators. We never ran out of PPE. For staff that couldn't work in COVID areas, we moved them from COVID areas. From that aspect, it was very accommodating. I don't know our data in terms of like how sick people were, mortality levels and stuff. I'll just say it's like clearly a devastating disease, and like we just as a medical community can and need to do better. I don't think that's Maimo specific. I think that's like us as a healthcare industry.
I think it was a couple of the hardest months of my life. I've never seen so much devastation, especially being such a new doctor as my intern year. I think that, you know, we got to do things that other hospitals didn't get to do. We got to have like high flow units. And that was in a way like one of our biggest uses and like or treatments for this disease, rather than jumping immediately to a ventilator. And I know that that's a lot of controversy. I'm not pitching a specific treatment, but I'm just saying we got to play because we had the resources to do so. And I would say every 2 or 3 days, our chair, Dr. Marshall, would come by and just be like, what do you need? How can I help you? Do you feel safe? And there's like a story we've always quoted is that he took off his own PPE to give it to someone else when in the beginning, every hospital was running low. So I think that's just like a type of love that.
Oh wait, Sabena, you just froze for like 40 seconds.
Oh man, it was so good. It was so good. I was just saying that we had like high flow machines. We had, in the beginning, not enough PPE, but then as soon as everyone realized that this was going to be an issue, every single person, especially our administration, was tapping into resources to get enough PPE. So from that standpoint, I felt very safe. It was a horrible, horrible time in every doctor's life. So that's not to be dismissed either. But from an administration standpoint, I feel very grateful to have been at this hospital. Please check out our resident panel on that too. It's a great, great question with so many nuances. Okay, so Ellen, there's another question. Is there a step 1 cutoff score for applicants to get an interview?
At Maimo, I don't know the answer to that. That's above my head. At other institutions, there are. Some of them will say that. They'll say, like, we strongly prefer scores greater than, 210 or whatever it is. I don't know the answer for our hospital, but if you take a look on, like, official recruitment websites for other places, then, yeah, there often are. I would not let that stop you from applying there.
I'm going to say I doubt that we have a hard number, but I can't speak to it exactly. There is going to be a session with our clerkship director and our interim program director, and I'll post the flyer at the end of this session as well, so you have those dates, and trust me, you're going to get spammed by us a little bit, just so you remember when we have some of these helpful sessions. And I encourage you, anonymous attendee who ask that question to them too, and you have like the blanket of anonymity, get answers, and try to push for a little bit of transparency. You deserve that. Ellen asks, thank you for this session. What are you looking for in the description of work/research/leadership? What details should we be sure to include, and what do you think is irrelevant?
Sorry, can you say the question again?
She's just asking about that section in ERAS where you talk about your work, leadership, and research. What should we include? What's too much information?
Usually there's no such thing as too much information. I think you would be surprised at like the amount of like, not frivolous, but like super tiny things that people input. I'll say like all the things that I put into like more professional stuff, like every presentation I gave, even if it was in med school, even if it was for like on a clerkship, even if it was for like 4 people, if I made a PowerPoint, I put it on there. Any research you're involved in, obviously, in terms of like some of the more nuanced stuff, because I guess the question really is like, what can you put, what should you put on there that like may fit, may not fit? I mean, like I put that I was a waiter back in college and stuff. You'd be actually surprised how many EM people equate waiting tables to emergency medicine, like having multiple angry parties at the same time. So yeah, I don't know if it's work experience, and even if you feel like it's a little unrelated, or if it was like, especially actually if it was like a weird pastime you did. If you're like, I was like an Olympic juggler, I don't know if that's relevant. Like, I met one of those guys. He was very cool. Put your juggling into your application.
I totally agree. I was a non-traditional applicant. I took 5 years between undergrad and med school. Believe it or not, this is going to shock you guys, but I am older than Duncan. Just include that life experience. Like, you're interesting, and we want to know you. And you're asking about, like, how can I show my personality? How do I know if this is the right fit? This is how. Like, you show who you are, but by some of the experiences that you've culminated throughout your years. Tyler is asking, what is your favorite part about the wellness program at Maimo?
Oh, well, there was a time when we would all be able to go out to bars or restaurants or karaoke. Oh, Korean barbecue karaoke was my favorite, probably. Every Tuesday night was a really nice program put together by the Wellness Committee, which will be back someday once we enter phase 15 or whatever. That was probably my favorite part. We had a study going. Ooh, can I talk about this? I'm going to. I don't know this as a fact because I have not checked every single resident lounge in the country, but I believe that we are the only emergency medicine resident lounge with a massage chair in it for resident wellness. And I feel very well when I sit in it. I actually had our former program director from a couple of years ago, who actually just moved to Texas. He had this really great heart-to-heart with me about wellness. He's like, you have to remember that wellness is not free pizza. Wellness is not like, free giveaways and cookies. Like, wellness is really like enjoying your job. And this isn't necessarily on the wellness committee, but sorry, I'm just getting sentimental with like all 64 people that I've never met before. I just like love my job. So if there was no massage chair and there are no recess rounds currently, that's okay. My coworkers and my friends are awesome, so it's fine.
I completely echo that sentiment. This is a really, really cool job, and this is a really, really great hospital. Do you have any advice regarding those of us who cannot do away rotations? Our schools no longer allows us.
I saw that. That's a hard question. Yeah, get the slows where you can, get the modified slows where you can. I think it is appropriate to address that in a personal statement, without sounding like vindictive, but just saying like, because our school's policy was not to allow medical students to rotate at outside hospitals, ... I might make that apparent and known. I don't think there's anything wrong with that.
I really don't think that programs are going to penalize you for not having this experience in these times. And I think just showing that you're still passionate about this field. And I will also say, like, unfortunately, it sucks because you don't get that affirmation that you want to do this field too by having those extra 4 weeks under your belt. So just spending time like chatting with other residents or doctors, like real attendings who are ER doctors, to make sure that this is a place that you want to be is probably important, just from your own personal perspective. But I really, really hope that programs will not hold that against you. That just doesn't seem fair.
Just as a follow-up, Iman Ali asked, would you email programs to explain that? I don't know that there's a right answer for this. I'm sure every program will expect different things from different people. I don't know that I would like prophylactically email however many programs you're applying to, just to be like, oh, hey, look, just so you know, I don't have a slow and this is why. I would give it a minute. I would probably address it in my personal statement so they're going to come across it. And then if you feel like not enough interviews are rolling in, I would reach out to programs to be like, hey, I'm interested in your program. I just wanted to like re-express my interest, and also just clarify that like I don't have a letter from a formal academic emergency medicine program because da, 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 da.
And whether or not you get that interview invitation the first day it's out or the last day it's out, it doesn't matter. On the like match day or rankless day, it's all the same thing. So I agree. Shivam asks, what are some of the common routes or fellowships residents pursue after graduating from Maimonides?
Well, how many people did match the fellowship last year? It was like
9 out of 16 or 9 out of 17.
Yeah, it was awesome. So we had 2 people go to critical care, a bunch of people go to ultrasound. This year, David Elkin is looking at applying for sports medicine. I'm looking at trying to go into an education fellowship. We have 2 people looking at critical care. Bob Hoke last year, my boy Bob, went to Emory for EMS, which is super cool. We have an event medicine program at Maimonides, which is actually, in some ways, back up and running as we're planning to staff some pretty big sporting events coming up, which is really exciting. So EMS is sort of like a natural segue into that. I know some people have talked about some like informatics stuff this year, so we'll see what's going to happen with that. I think those are the big ones. Oh, and SIM, and we have SIM. Oh, and a lot of our PEDS residents, I guess that's irrelevant, they go into our pediatric emergency medicine department for fellowship pretty often, which is cool. So I would say the biggest ones, lots of ultrasound, critical care, education, EMS, Dave Elkin looking at sports medicine. Those are the ones that come to mind.
Ugo Chukwu asks, does the program afford any opportunities for community engagement with the lower socioeconomic communities?
Sabena, I think, can speak to some of that. Sabena had this project that she made in her like first week of residency where she got those like good RX cards to help underserved communities be able to afford their prescriptions even without insurance. I was once told by an attending that Maimonides will never make anyone go bankrupt. So we have our population is often referred to as the working poor. So everyone, or not everyone, a lot of people fall below the poverty line, but are still actively working. So that's sort of like our regular population. In terms of like outreach programs that the emergency department does specifically outside of the emergency room, I know there are a couple programs. I think like GW or something has one where they like go seek out like homeless people that need medical care, like in the middle of the night and stuff. Like we don't have anything in place like that. So to answer your question in a specific way like that outside of the department, no, we don't.
I think those are projects that are actually in the works right now. Like there's an arm of social EM that's actually just starting to kick off this year. And I think through that we have a, what's it called? A free clinic that'll probably be opening up. We do a lot of Suboxone management, which I know is not necessarily SES related, but I do think it's a specific like underserved community in a way. And then I think a lot of our patient population, for me, when I was applying to the residency, I really wanted to be in a program that like would have some of that county vibe type of patients. And I think that itch has been fulfilled here, which is cool. Someone is asking, is there support for people interested in global health, social EM, and even health policy?
We have a whole global health rotation, international health rotation that the seniors typically go on. Obviously, this year's a little weird, but they've gone to, oh gosh, where have they gone to? Like Vietnam, Italy, I mean, all sorts of places, like literally around the globe. And everyone comes back at the end of it and shares a presentation about what they learned and like about the healthcare differences between the United States and other countries. Really, really cool stuff, really fascinating stuff. One of our attendings, Josh Schiller, is in charge of it, and he's extremely passionate about global health. There's also selective time during third year, so if you wanted to, you could even do another international rotation. You do multiple if you wanted. So it's actually a part of our program that's actually already built into the rotations during your third year.
Yeah, I would definitely say there's some foundation for all of this. And if this was an area for interest, you could probably find attendings that could help you grow that interest. And then it's still something that's also under development. So everything hasn't already been created, which is fun for residents too, because you get to create your own legacy and you get to find projects and then run with it, which I can't think of anything that's more fun than that personally. I think that I'm going to share my screen right now and just remind you guys about the awesomeness of this web series that is to come. Thank you for spending these past 80 minutes with Duncan and me and learning a little bit about how to be a even better medical student. I'm sure you're already great, but even better, listening to Duncan and me chat. And just want to quickly pitch this one more time, that this is our Zoom webinar series. July 28th is our next one. I keep switching. July 28th is our next one, where you can join Dr. Modi and Dr. Kerbedin and Dr. Lee about basically answering all of your questions about why Maimonides and questions about the application cycle. So I'll leave it at that. Thank you, guys. Thank you, Duncan.
Sorry, I was muted. Thank you, everyone. It was nice virtually meeting you, but nice getting to talk to you. And please, please email me with any questions.
And I just posted mine to the chat as well. I'm sabena@gmail.com. Any questions, no one has to know that you even emailed if you have any anonymous questions too. Good luck. You guys are great. You got this.
Bye, everyone. Good night.